Well, we're now at 4 o'clock UK time. I'd like to welcome you all, wherever you're joining us from wherever in the world you are, to this webinar, which is organized by Medical Society, the Fellowship of Postgraduate Medicine. In brief, we aim to provide authoritative updates, advances in medicine. We publish 2 journals, the Postgraduate Medical Journal, which has been around since 1925, and a new journal, newish journal called Health Policy and Technology, which has been with us now for 10 years. And I'm delighted that today's topic is going to be new developments in thyroid disease. Without more ado, I'll hand over to my FPM colleague, Dr. Willem Elte, to introduce our panel today. Over to you, Willem.
Thank you, Donald. My name is Willem Elte. I'm a retired internist endocrinologist from Rotterdam and Gouda in the Netherlands. And it's my pleasure to introduce the 2 speakers of today. Dr. Edward Visser is a clinical endocrinologist at the Erasmus Medical Center in Rotterdam. And he had his clinical training in Rotterdam and in Cambridge. And he's head of the Rotterdam Thyroid Center. His major interest is rare thyroid disease and particularly thyroid hormone resistance, but he's also interested in interpretation of thyroid function tests in pregnancy. He is executive committee member of the European Thyroid Association. His presentation is entitled Abnormal Thyroid Function Tests. Dr. Tim Korevaar received a similar training in Rotterdam, but also spent time in Oxford, Cambridge, Boston, and very recently, he was a visiting clinical fellow of obstetric medicine in London, still being in training in internal medicine in Rotterdam. Thyroid and pregnancy is his major area of scientific interest. And he will speak about an update on the management of thyroid function test abnormality in pregnancy. It's also a privilege to introduce 2 distinguished discussants, highly regarded experts in the field. Dr. Carla Moran is clinical endocrinologist and associate professor in Dublin. Her main interest is also resistance to thyroid hormone. And besides, she's interested in discordant thyroid function. Dr. Moran is a member of the European Guideline Committee on Thyroid Dysfunction and Resistance to Thyroid Hormone. She's also the current secretary of the British Thyroid Association. Professor Kristien Boelaert, also clinical endocrinologist and training director at the University of Birmingham. She's in the lead of the NIHR Guideline Committee on Management of Thyroid Disease. And her research interests include, amongst others, endocrine disorders, especially the thyroid, in pregnancy. And all 4 have extensive publication lists, members of several committees and editorial boards.
Good afternoon. Welcome by this first part of the webinar. This afternoon, I'd like to share a couple of slides, a couple of cases, in order to refresh the workup for abnormal thyroid function tests. And to recognize the main features in thyroid hormone resistance. So let's get started with this first patient, who is a lady of 40 years, referred by the GP to my clinic because of abnormal thyroid function tests. She had presented with complaints of tiredness, and the GP thought it was appropriate to rule out thyroid disease. She was doing fine otherwise, and she was not on any medication. So hi, okay. Good. So we see most of you voted for an assay problem, but in fact, there are also between 10 and 20% for all the other cases. So the good news is that all answers are correct. But so let's continue and see why all these answers were true. So although I presume we all know how to interpret thyroid function tests, I found this schematic representation of different combinations quite helpful. It was drawn by Olympia Kaluri and Mark Gurnell from Cambridge. And those are the easy ones. So in gray, the euthyroid situation and the hypo and hyperthyroid situation. But what about the 4 other groups? So these 4 groups, let's see where this is, have a unique combination of TSH and FT4, and they're associated with a list of possible causes. And obviously there's not enough time to go into detail of each group, but our patient belongs to this group. So she had an elevated free T4 and a normal TSH. And there are a number of causes to be checked. But among all the different possibilities, SA interference seems to be everywhere. So it seems appropriate to rule out any interference first as a cause. So the first step in the workup of the abnormal thyroid function tests is for sure to take into account the clinical context and medication, etc. And as a second step, to confirm the validity of the measurement. The thyroid function test should be repeated on different platform, which is what we did. So on platform B, we found basically a similar outcome. But on platform number C, which is the Vitros assay from Johnson & Johnson, we noted that FT4 concentrations were rather low. And when we see this, actually when we saw, because we changed platforms, but when we saw this combination with FT4 in another platform high and in our platform low, that was actually kind of diagnostic for FDH, familial dysalbuminemic hyperthyroxanemia. And just to recall, so FDH suspicion can trigger a number of diagnostic tools. So we employ gel chromatography by adding radiolabeled T4 to the serum. And as you can see in this chromatogram of a normal individual, most of the T4 is bound to TBG, a minority to albumin, and also some T4 is bound to transthyretin. However, in patients with FDH, they have a mutation in albumin, resulting in a stronger binding of T4 to albumin. And in the regular FT4 assay, that results in less available T4 tracer for competing with the antibody, resulting in a falsely high FT4 estimate in most assays. Our particular assay resulted in an underestimation due to a difference in the buffer composition, but I'll leave that for now. And a second test is a genetic test with a gene analysis in the albumin gene, and that revealed in this case the typical arginine to histidine mutation at position 242. So this slide shows the free T4 concentration in a cohort of individuals with FDH measured on different platforms, done by in collaboration with our colleagues in Cambridge. And what's important to get from this slide is that each assay has its own behavior when confronted with FDH. So it's also important to get to know what assay is used in your lab. And obviously I used the FDH case to illustrate that there's assay-specific interference, but that can also occur for other types of interferences. So it's really good to get to know your assay. So to summarize this, this part, so when it comes to workup of abnormal thyroid function tests, it's quite obvious, but think of the clinical context. Might it be interference due to antibodies or medication? Are there other underlying diseases? It's really important to know your assay platform, and if you don't, you should know the number of your clinical chemist, and it's paramount to repeat the thyroid function tests on a different platform. So let's move to the next case. And this is a lady of 43 who presented to my clinic. She had a medical history of atrial fibrillation when she was in her 30s, which is quite unusual. And in her family history, she had 3 children, and 2 of them had ADHD. And also her father had atrial fibrillation and other cardiac abnormalities. She actually had she quite suffered from palpitations, and she had frequent stools every day, but except that there were no other abnormalities. So these were the medications she was using, and on examination, there was only a goiter, and otherwise she there was no noticeable abnormalities. When testing the thyroid function profile, you clearly see the elevated 3T4 concentrations and also T4 and T3 concentrations in the context of a normal TSH. So 2 of her children had exactly the same pattern. Also SHBG, sex hormone binding globulin, which normally responds to T3 concentration. So an elevation in T3 normally triggers an increase in SHBG. And that was not the case in this family. So we pursued genetic testing, and that revealed a mutation, actually deletion of a glycine at position 432. Now, to understand the basis of thyroid hormone resistance, I would like to remind you of the concepts of cellular regulation of thyroid hormone. So this slide indicates a T3 responsive cell, and as a first step, the thyroid hormones need to cross the plasma membrane. So one of the most important, if not the most important, plasma membrane transporter is called MCT8, facilitating cellular entry of the hormones. So once inside the cell, there's the set of enzymes called deiodinases that can either activate or inactivate thyroid hormone. And in the nucleus, there's the T3 receptor, the thyroid hormone receptor, that actually functions as a ligand-dependent transcription factor, and upon binding of T3, it initiates a transcriptional program dependent on T3. So patients with a defect in the thyroid hormone receptor, so either there's no T3 binding or diminished T3 binding, or with a higher affinity, that results in a disruption of the normal sensitivity of the receptor to T3, and also the normal transcription of T3 dependent genes is changes. And this together is called the thyroid hormone resistance, or also impaired sensitivity towards thyroid hormone. So there's not enough time to dig into the molecular determinants, but to touch upon the pathophysiology, there are 2 thyroid hormone receptors, TYR alpha and TYR beta. They have a distinct expression pattern. So TYR beta is mainly expressed in pituitary and liver. TYR alpha is mostly expressed in heart and skeletal muscle, in bone, in gut, and in the brain. So how to explain the abnormal thyroid function tests and the clinical picture in patients with a defect in TYR beta? Let's see, to move to the next slide. So the pituitary does not adequately sense the thyroid hormone concentrations. So in a normal situations, elevated T3 and T4 would suppress TSH, but that's not the case if there's inadequate sensing. Rather, TSH seems to have an increased biological activity, producing the goiter and the elevated thyroid hormone concentrations. Also tissues like the liver that also harbor a mutated TR beta, they will not sense the elevated thyroid hormone concentration in the blood. And that results in a relatively hypothyroid state of such tissues. And that also explains the normal SHBG concentrations in this family. And there's also a tendency to increased cholesterol levels. On the other hand, the TYR alpha expressing tissues normally sense the increased circulating thyroid hormone concentrations, and that explains the increased heart rate and increased stool frequency, and so on and so forth. So on this slide, I've summarized the main clinical characteristics. So some patients do not have any clinical problems, but only the typical biochemical pattern and a mild goiter. This is explained by the fact that T-beta tissues can be compensated by the elevated T4 and T3 concentrations, resulting in a net euthyroid state in most tissues. However, there is also a group of thyroid hormone resistance patients that display variable features of tissues that are either hypo or hyperthyroid. So tachycardia is quite frequently noted. Also problems of the central nervous system, learning and concentration difficulties, particularly in children, occur, and also in childhood there can be a delay in bone age and a delayed growth. So if interference is excluded, then the elevated T4 and non-suppressed TSH concentrations are quite typical for RTH beta, so thyroid hormone resistance due to a mutation in the beta receptor. However, it's important to distinguish this from TSH producing pituitary adenoma, because they can also present with such biochemical features and also variable features of thyrotoxicosis clinically. So now we come to our next question. So what test is most adequate to distinguish a TSH-OMA from RTH beta? Okay, so that's so most of you voted for the TRH test. Actually, I also voted for the same option. So, and that's basically nicely summarized in those papers, where they compared a group of TSH-OMAs and RTH patients. So there's no difference in T4 and T3 concentrations. However, the TRH test, so where you inject patients with TRH and then measure TSH afterwards, there's a striking difference. So typically the TSH response in a TSH-OMA is flat, so a less than twofold increase, while in RTH there's an exaggerated TSH response. So there can be other tests performed like SHBG, although that's there's quite some overlap between the two groups, and it's also possible to have a T3 suppression test, but yeah, in our hands, a TRH test works well actually. So the final diagnosis comes from a genetic test, so sequencing the TR-beta gene. There are hundreds of mutations reported. They cluster in a number of hotspots. The incidence is like 1 in 40, 1 in 50,000. And there's also between 10–15% of cases in which a mutation cannot be found. And it's not entirely clear how to explain that, perhaps by somatic mosaicism or mutation in other genes, or perhaps an occult TSH-OMA. So when it comes to treatment, how would you treat the tachycardia of this patient? Yes, so most of you would vote to treat with a beta blocker, and I think that's absolutely right. When it comes to treatment, so in asymptomatic individuals, it's important to not lower T3 and T4 by either antithyroid drugs or radioactive iodine, because that will result in symptoms, and because the partial tissue resistance is compensated by the increased endogenous thyroid hormone. And if you lower that, that might produce symptoms. A number of patients that present with tachycardia are well treated with beta blockers, and there is a minority of RTH beta patients that cannot be managed with beta blockers or might have other indications. And for that very selected group of individuals, the T3 analog triac, perhaps in combination with antithyroid drugs, might ameliorate some symptoms. So to summarize the main feature of RTH, so patients have goiter and variable features due to exposure of high T3 in TR-alpha tissues. Biochemically, they're characterized by elevated FT4 with non-suppressed TSH concentrations. Obviously, assay interference should be ruled out, and it should be distinguished from TSH-OMA because that has a completely different management. Treatment is usually not needed. Tachycardia can usually be well managed with beta blockers, and in incidental cases, triac can be of use. And it's important to regularly check the thyroid function tests, lipids, and also do a DEXA scan. So from my part of this presentation, when you're confronted with abnormal thyroid function tests, it's quite logical to really take into account the clinical context, disease, medication, etc. Really try to know your assay or your clinical chemist. Repeat thyroid function tests on a different platform. That's usually very valuable. And also realize that once in a while there can be rare thyroid hormone signaling diseases like thyroid hormone resistance underlying the abnormal thyroid function tests. I'd like to thank you for your attention.
Thank you very much, Edward. And I think that there can be questions from the audience through the chat function. But first of all, I would like to ask Carla Moran whether she has comments or questions. Carla, please.
Thank you very much, and thank you, Edward. It's a lovely overview. And whenever I hear these talks, I always learn something new. And I think it's really fascinating because we see patients with abnormal thyroid function tests, discordant thyroid function tests all the time. And even though I'm assessing these patients all the time, sometimes I'm surprised by what turns out to be the diagnosis. But my approach is very similar to Edward's, actually. I suppose the only additional things that I would say that I think are just kind of clinical nuggets are that I like to try and get any old or previous thyroid function tests that have been performed, because sometimes you might see somebody who's got quite a complicated pattern. You're wondering maybe if they've got resistance to thyroid hormone beta. You're not quite sure, but if you're able to dig up thyroid function tests from a number of years ago that clearly shows normal T4, T3 and TSH, then at least you can exclude some conditions. And I think the other thing that's quite helpful to do, that I try to do, is to check familial thyroid function tests, because that's a very inexpensive way of trying to determine whether there's something inherited going on. So again, whether this could be resistance to thyroid hormone beta, or indeed whether there's assay interference that is inherited, like FDH, like the case that Edward had there. And I suppose the other things that I would add would be, I definitely concur with sending it off to another assay. And I think it's very worthwhile knowing your own assay, and also having another assay that you can avail of, but one that you understand the behavior of that assay. Because if you're using, for example, a Roche assay and you send it off to another laboratory with a Roche assay, you won't get any further. You might think you've excluded interference and you haven't actually done that at all. And the last thing that I would absolutely concur with is about phoning your biochemist. And so what I often say to trainees is that we are so used to going down and speaking with radiologists if we've got an unusual MRI pituitary scan. We do that all the time. We do it without thinking. And I think that we should regard our clinical biochemists in the same way and pick up the phone and say, these thyroid function tests don't make any sense to me. Can you help?
I fully agree. I think with all the additional points Carla made, I think if possible, it's great to get historical tests and also try to get a family in, and that can be really helpful. Although I always have in mind, indeed, you might pick up inherited conditions, but you might miss kind of de novo mutations. But I think this whole all those things together can be really, really helpful indeed.
I'm going to pick up a couple of questions in the chat. One's from Anna, and the question is, how common is osteoporosis in thyroid hormone resistance?
So while I was in the UK, we looked at a cohort of patients with confirmed resistance to thyroid hormone beta with a mutation in the THRB gene. And we measured the DEXA scan in over 50 such individuals. And their T-score is a little bit reduced, but only marginally so. So I think it was 0.1 to 0.2 lower than one would expect. So I think their bone mineral density is certainly a little bit reduced, but it doesn't have, as far as I understand it, you know, a very significant effect on their bone health. But having said that, I personally recommend that they have a DEXA scan performed. And then I would repeat it again based on what their initial bone mineral density is like. So if they've got a very reduced bone mineral density, you might decide to repeat it in 2 years. If everything looks okay, it might be reasonable to repeat it in 5 years.
Okay, thank you. There's another question about why is cholesterol level raised in THR? Is there an explanation for that?
Yes. Oh, I don't know, Carla. I mean, you can go ahead as well.
So we think that that reflects the hepatic resistance to the action of thyroid hormone. And it's quite interesting actually, because these patients have higher total cholesterol. They have a raised LDL cholesterol, but they also have a raised triglyceride, which is not readily explicable by the hepatic resistance. And they have lower HDL than controls. So they have a dyslipidemic pattern. So we think that the majority of that is explained by hepatic resistance. But we know that the alpha form of the receptor is expressed on adipose tissue. And so we wonder whether it's the increasing signaling through the alpha in the adipose tissue that may be perhaps generating triglyceride and perhaps resulting in this dyslipidemia rather than it being a pure hyperlipidemia.
Perhaps I may add, because I left a question for you. If you want to have some more detailed reading, Carla published a paper particular on this subject in the JCM, I think actually this month, Carla. So congratulations. But for any detailed reading, please have a look there.
Okay. Can I ask Kristien, do you have any comments or additions or not now?
I just wanted to verify that, you know, what my usual ways of investigating this sort of step by step and whether everyone on the panel agrees. So you get someone with funny thyroid function tests, as we discussed. We look if there's old ones, if we have some on other assays, if there are any family ones available. I then send it off to my lab for a screen where they do an FDH screen, but also check for heterophilic antibodies, which I don't think we've touched upon. And we send it off to another assay. If that doesn't reveal anything, then I would do an SHBG and a alpha subunit concentration, followed by a TRH test. If that, you know, if they are raised, if SHBG and alpha subunit are raised, then I'll probably get a pituitary MRI scan and do a full pituitary function. If that doesn't give me the answer, then I do a TRH test, and then I would send off for sequencing. In a nutshell, is that, am I doing the right thing?
Edward Hotel.
Yes, I think that I think that basically would capture the whole process. Personally, I mean, if I understand you correctly, you first do SHBG, etc., and based on that, you would continue with TRH test. I think we might do that as well, although I think I wouldn't kind of land too heavily on SHBG concentrations, and quite quickly proceed with a TRH test. Yeah, actually, I must say we get quite some referrals also from other centers, so we are in the luxurious position that many of those tests have already been done before they are referred to us. So yeah, but I wouldn't actually, at least in our hands, and I don't, perhaps Carla can comment as well, the TRH test seems to work quite well in differentiating the TSH-OMA from RTH.
Yeah.
We have a question from, sorry, go on. A question from Wade here on genetics. And I think underlying this, he's asking about family testing, but it raised the question to what extent these are spontaneous mutations versus well-established and very occasional spontaneous mutations.
What the ratio is, yeah, I don't have a number, but I would say I would say that the majority of RTH is inherited. Although, yeah, I'm also aware of a couple of de novo mutations. So yeah, but my guess would be it's the minority that is de novo. What do you think, Carla?
Yeah, I would agree with that. I had a figure in my head of about 15% are de novo, that kind of range, so pretty low.
15?
So I think there's two comments I'd make on that. So the first thing to say is that somebody who's acutely psychiatric unwell, we have seen patients that can have a pattern of a normal TSH raised T4, raised T3. It can actually look like resistance to thyroid hormone beta. But in actual fact, when you treat the primary psychiatric problem, the thyroid function test normalize. So we feel that this is a reflection of a form of non-thyroidal illness. I've seen such a case within the last year. So that's one consideration. And the other thing to say is on the flip side, patients with RTH beta, although they do have an increased frequency of anxiety and attention deficit hyperactivity disorder, quite severe psychiatric illness is not known to be more frequent in those patients.
Tim, can I ask you to start your presentation, please?
So thanks everyone for the kind invitation to this great webinar. This is going to be a very condensed talk to provide the best possible update on the management of thyroid function test abnormalities in pregnancy. I guess we'll take some time to go into more details during the question session rather than my talk. So I'm going to start and discuss hypothyroidism. After that, also milder forms of thyroid function test abnormalities. And then in the second half of this talk, I would like to provide some new insights into the management of Graves' hyperthyroidism in pregnancy. So with regards to hypothyroidism, we've seen many of these types of studies. I think this Dutch study is probably the most important one, most well-known one that we've had, suggesting that because of the stimulatory properties of HCG on the thyroid gland, we need to lower the thresholds that we use for diagnosing hypothyroidism, specifically the upper limit of TSH, of course, that is. And in the previous ATA guidelines and also some other guidelines, it has been advocated to use 2.5 milliunits per liter in the first trimester and thereafter 3 milliunits per liter. I want to make the point that we should no longer be using those reference ranges based on these studies. And the reason for that is that we now have much better data actually to interpret thyroid function tests in pregnancy and make reference ranges. So this great study by Alex Tegnero-Green was a meta-analysis of the literature and reference ranges. And what he actually showed is that if you use these upper limits of 2.5 and 3 milliunits per liter, you actually overdiagnose otherwise healthy women during pregnancy with hypothyroidism in about 1% of cases, and 1 in 9 women will actually be overdiagnosed with subclinical hypothyroidism. So actually huge numbers. Now I'm going to show you the most recent recommendations from the American Thyroid Association guidelines, which are probably the most up-to-date ones. And there, the third step that a lot of centers will end up using eventually would be to increase the TSH upper limit for the diagnosis of hypothyroidism to 4 milliunits per liter. And you can see in this slide that that effectively kills the large overdiagnosis with the former cutoffs that were used. So here is this overview on the left side of the current ATA guidelines. The sort of gold standard that's typically recommended to use is to calculate your own reference ranges. You need a group of about 400 otherwise healthy pregnant women, and then exclude TPO antibody positive women and also other subgroups, and then calculate your own reference ranges for TSH and free T4. Now, for many centers, such reference ranges are unavailable. And the second step is then to sort of adopt reference ranges that have been calculated in a similar manner in a hospital that uses the same assay as your hospital and has also a similar population. Now, in the recent hospital where I've worked in London, in Queen Charlotte and St. Thomas Hospital, I tried to adopt these reference ranges, but it turns out it can actually be quite difficult to extract reference ranges that are actually well adoptable to your own reference range, to your own population, sorry. So what you often end up with is this fixed TSH upper limit of 4 milliunits per liter. What sometimes happens is that this change in the use of the 2.5 cutoff is also projected to treatment targets that we use in pregnancy. And this should not be confused, because the treatment target for any woman receiving levothyroxine in pregnancy is still being recommended to be less than 2.5 milliunits per liter. And that is on the basis of the picture on the right part of my slide, which has to do with the majority of the women being within this limit when they are otherwise healthy, and also because we want to reduce the potential risk of undertreatment and strive for a TSH above 2.5 in case the demand for thyroid hormone increases in pregnancy, so that we don't lag behind with increasing the dose if necessary. So how about milder forms of thyroid dysfunction, especially subclinical hypothyroidism and hypothyroxanemia? The main question here is, and has always been, I think, to treat or not to treat. And the short answer for subclinical hypothyroidism is that we really don't know, and that we should really also be aware of some newer data indicating that we can actually overtreat women with mild thyroid function test abnormalities, especially if we treat them with a full dose that we would otherwise do with overt hypothyroidism, for example. Now, to give you a bit more details, we know that there is a small randomized controlled trial by the group of Faridun Azizi, where they showed that if you treat women with a TSH above 4 milliunits per liter in pregnancy, you can reduce the rate of preterm birth quite substantially. And this seems to be particularly true if those women are also TPO antibody positive. So also observational studies have shown that TPO antibody positivity combined with high TSH concentrations gives a much higher risk of adverse outcomes than the separate entities on itself. There have, however, been 2 large randomized controlled trials from the UK, Italy, and the US, in which treatment of subclinical hypothyroidism did not reduce the risk of adverse pregnancy outcomes. And the main disadvantage that we have with interpreting those data is that they didn't split up the TPO antibody positive from the negative women. So from those studies, we can't really say anything about this potential higher risk in TPO antibody positive women with subclinical hypothyroidism, unfortunately. So in general, I think if you find a high TSH in a pregnant lady, then it would definitely make sense to check the TPO antibodies, because it can help you in clinical decision making. And if these are positive, then the current ATA guidelines do advocate that you start treatment with levothyroxine at a relatively low dose. So that's only 50 micrograms per day. And then of course, check the TSH and see if the dose needs to be changed or not. And then if the TPO antibodies are negative, what you end up with is a really difficult gray area, where also the guidelines say that you can consider levothyroxine treatment, but they don't give a full recommendation for it. And in this case, if you do decide to treat, then make sure again that you don't overtreat, and again start with a relatively low dose of levothyroxine and up titrate your treatment. How about hypothyroxanemia then? Well, I think the same issues are attributed here. So the short answer is, again, we don't really know if you should treat. Although if you look at the data that we have, it's slightly of less quality than we have for subclinical hypothyroidism. So again, the 2 large randomized controlled trials that have been negative in this field also looked at hypothyroxanemia, didn't find any benefit of treatment. And then we only have prospective observational studies indicating that there might be a higher risk of preterm birth or slightly lower IQ in the offspring. So because we don't have as much data here, my general considerations for hypothyroxanemia is to follow up thyroid function tests when hypothyroxanemia is first identified in the first 18 weeks of pregnancy. But if it's after 18 weeks of pregnancy, you could even consider to not follow up this thyroid function, because it's much more likely to be an assay artifact in later pregnancy than it is in early pregnancy. So Graves' hyperthyroidism then. One of the main questions in this particular field is, of course, should we go for PTU or methimazole carbimazole when we think about treating Graves in a lady who wants to become pregnant or is pregnant? And there is some great data from the Danish cohorts and the Korean studies, which basically show that there is an absolute risk increase for fetal birth defects with both PTU and methimazole. However, it's slightly lower for PTU compared to methimazole. As you can see, the absolute risk increase is about 3% to 5%. But what we also see is that the fetal birth defects that are generally contributed to PTU seem to be less severe than those that are contributed to methimazole or carbimazole. So that's for that reason particularly, we would favor PTU in a woman who has a desire to become pregnant or is pregnant. Another argument in favor of using PTU over methimazole is that in this Korean study, as you can see in the top of my slide, they actually found there to be a cumulative dose-response relationship for methimazole with regards to the risk of fetal birth defects, but this was not the case for PTU. Follow-up question is then often, well, what do I do if I see a pregnant woman who is actually already on methimazole and has a positive pregnancy test and comes in at 6 to 8 weeks of pregnancy for her consultation? And this is the only study that has compared women who are switched in the first trimester from methimazole to PTU and compared those women to those that continued methimazole or carbimazole usage throughout pregnancy. And actually, they didn't find a risk difference between these groups in the risk of fetal birth defects, implicating that there's a risk of biochemical deterioration once we start to switch anti-thyroid drugs, but there probably is not much benefit from the point of the risk of fetal birth defects. So we need other strategies to limit exposure to anti-thyroid drugs. And one thing that we can do is we can use the time trajectories related to the relapse of Graves' disease and overlap that with the teratogenic period. So here you can see a graphical outline according to a timeline of the teratogenic period, or what's it generally considered to be. And we all know that the risk of relapse of Graves' hyperthyroidism after you stop anti-thyroid drugs is not 100%. And if it does relapse, then typically on average, it would relapse after about 3 months. So with a little bit of luck, if we stop anti-thyroid drugs during early pregnancy, we can actually bypass the teratogenic period. And in the 70 to 30% chance that Graves' hyperthyroidism does relapse in pregnancy, hopefully we are already past the teratogenic period, limiting exposure to anti-thyroid drugs in the period that it is most important. You can't do this in all women who have Graves' disease. Generally, you can only consider this in women who have mild Graves' disease. And here on my slide, you can see some of the recommendations by the American Thyroid Association guideline to make that distinction. So you can see that they need to be treated for at least 6 months and well controlled, and also be on a low dose of methimazole or the equivalent of PTU. So I want to end with some final thoughts on assessing the risk of fetal and neonatal hyperthyroidism if the mother has Graves' disease. We all know that Graves' hyperthyroidism can affect the child because the T-stage receptor antibodies pass the placental barrier, as is shown on the left part of my slide. Luckily, also anti-thyroid drugs pass the placental barrier. But in case we cannot biochemically control the mom or the child, fetal and neonatal Graves' hyperthyroidism really are a major risk factor for preterm birth. also severe intrauterine growth retardation, and also early neonatal death, unfortunately. Now, another thing, sort of a clinical pearl I'd like to share with you, is that if there has been poorly controlled maternal disease in pregnancy, we should also liaise with the pediatricians, because studies have shown that in the children born from uncontrolled pregnancies, there is actually quite a high risk that the child develops a form of central hypothyroidism. And in those children, it may be sensible to follow up thyroid function on a yearly basis, or even do a TRH stimulation test. So during pregnancy, we monitor the child. We have typically brilliant obstetricians who can do a lot of very cool things with ultrasound, look at the thyroid size, and also, of course, the general growth of the baby. But we also do, of course, maternal monitoring. And maternal monitoring is another insight into the thyroid function of the fetus, and also the amount of thyroid hormone availability, of course. So here you can see a study from our group on the left, where we essentially replicated other studies showing that there is a very strong association between maternal thyroid hormone concentrations and that of the child at birth. And the study on the right is, I think, very interesting, although it's from 1986, still highly relevant. So in this study, they looked at the thyroid function of women treated with antithyroid drugs for Graves' disease in pregnancy. And then on the y-axis, you can see the number of newborns that were born hypothyroid. And what they found was that if the maternal free T4 concentrations are in the lower 2/3 of the normal range, or even below the normal range, there is quite a substantial risk of newborn hypothyroidism. But this risk is much lower if we try to titrate the antithyroid drugs dosage to a free T4 concentration in the upper third of the normal range. And that's where those recommendations that are still relevant today actually come from. What we also try to interpret is, of course, the TSH receptor antibody concentrations, because they're also associated with the severity of neonatal and fetal disease. And what's interesting to note is that if you summarize all the literature that we have so far, there has not been a single case of either fetal or neonatal hyperthyroidism described in which the maternal TSH receptor antibody concentration was less than 3.7 times the upper limit of normal, so for your specific assay. So therefore, I think it's sensible to state that if the TSH receptor antibody concentration is below 3 times the upper limit of normal in early pregnancy, it's not really necessary to follow up TSH receptor antibody concentrations throughout pregnancy, because we also expect that to see the natural decline due to pregnancy immune modulation. And you may even consider to de-intensify the follow-up, for example, fetal monitoring and ultrasound scans, as long as the mother, of course, stays well controlled with her antithyroid drugs. So I'm going to shamelessly plug some of the work that we have been doing in the Consortium on Thyroid and Pregnancy. You can visit our website. We're trying to collect data from all over the world to do new studies, especially on mild thyroid function test abnormalities and its clinical consequences. But we're also trying to set up new prospective studies. So I hope to see you participate in those perhaps in the future. And here's a lot of people I'd like to thank, but I would also like to thank you for your attention, of course.
Okay, thank you very much, Tim. Very clear presentation again. And first of all, I would like to ask Kristien whether she can comment on this. And
thank you, Tim. That was, as always, a very clear overview. So I think the points, if I can emphasize some points first, which I always agree with everything Tim says, of course. So I think when we look at thyroid hypofunction, very much the message is less is more. I think we've been over-treating this for a number of years. I think there is emerging evidence that maybe over-treating women with mild thyroid hypofunction may have adverse effects. I have a few questions on this to Tim as well, as in, so he highlighted the trials that have been done, where I think the consensus is that probably the treatment that was started for subclinical hypothyroidism an isolated hypothyroxemia was probably too late in gestation, and how feasible he thinks it is that we may get more evidence where actually we start earlier on in pregnancy, because I very much am of the belief that the sooner you start in pregnancy, the better to normalize thyroid function. A further thing that wasn't touched on, because of course we can't touch on everything in this symposium, is TPO antibody positive women, and especially in the sort of fertility and recurrent miscarriage setting, where it's very clear that women who are TPO antibody positive, even if they have normal thyroid function, and again, it's then how do you define this, the evidence emerging that even if you treat that with levothyroxine, you don't actually improve outcomes. So it may be that that is not driven via thyroid function, but that it's a more sort of generalized autoimmune effect. And then the final comment I wanted to make, looking at the hyperthyroidism side of things, is that in my experience, Graves' disease in women who have pre-existing Graves' disease often gets better in pregnancy. So even if we continue anti-thyroid drugs through the first trimester, it's actually very rare that once they've reached 16 to 20 weeks, I still have to continue. In most women, I can stop it. And I think the message here very much is always try and use the lowest possible dose and stop if you can. Newly presenting Graves' disease, I have seen it in pregnancy, but it's very rare. And so if someone presents with thyrotoxicosis as a new diagnosis in pregnancy, just be aware that this is likely to be transient hyperthyroidism of pregnancy, usually linked to hyperemesis. But so that was a question to Tim about, what's the feasibility of getting earlier trials, and then a few comments. And I think there's also a few questions in the chat.
Thank you, Kristien. Addition, Kristien. I think you're absolutely right and spot on with all the points that you've made. I think we can do another 15 to 20 minutes at least to discuss all of those very interesting but important concepts. With regards to your question, I think you're absolutely right about the evidence that we have from current randomized controlled trials. We know that treatment with 150 microgram of women who have subclinical hypothyroidism or hypothyroxemia is probably more likely to do harm than actually cause benefit, like we learned from the CATS trial. And then if you look at the trial from the NIH where Brian Casey, the lower dosage of levothyroxine was used in those trials of about 50 to 75 micrograms, but they only started treatment around 18 to even 21 weeks of pregnancy in those groups, which is probably already past the window of opportunity, as studies from our group and also others have recently implicated. So, the way to go, like you already suggested, would be to do earlier, to do trials in which we start with levothyroxine earlier in pregnancy. And another argument for that is probably also because I think that the meaning of subclinical hypothyroidism diagnosed around 10 to 12 weeks of pregnancy is probably much different than when you diagnose it at 18 to 20 weeks of pregnancy. And that, of course, has to do with the fact that the thyroid is very much stimulated due to the high HCG concentrations in earlier times of pregnancy. So failure to respond to that stimulation is probably also something that could be a reason to treat women, but this is of course very speculative.
Thank you.
Thank you, Tim. There are questions from the audience. There's one asking about contraindications for taking iodine supplements like seaweed in those who have hypothyroidism.
Luckily, severe iodine deficiencies is practically eradicated from the world because of iodine supplementation policies. I think it's really difficult to diagnose iodine deficiency related hypothyroidism, especially in pregnancy with the changes in renal function, etc. So I don't think that iodine supplements would be a sensible way to treat hypothyroidism in pregnancy, because if you're wrong, then you can potentially cause a lot of damage. So if you suspect there is an iodine deficiency, it would probably make more sense to start levothyroxine and iodine. But in general, yeah, we don't see it as often anymore. Not sure if Kristien has anything to add.
Yes, I think if women are treated for hypothyroidism with levothyroxine, they should get sufficient iodine from the levothyroxine that you give them. And, there is, I think taking seaweed extracts and all sorts of natural supplements probably is not advisable. I don't think there's a problem in women on levothyroxine also taking a pregnancy supplement, and the majority of pregnancy supplements will have some iodine in it, and I don't think there's a problem with that. But I wouldn't give them high doses of kelp, for example.
Thank you. There's a question about what level of FT4 in hypothyroxanemia would you suggest to start on thyroxine therapy?
So I'll go first and maybe Tim can comment. I don't treat hypothyroxanemia in pregnancy. The American Thyroid Association guidance says not to treat. European Thyroid Association guidance says consider treatment in the first trimester. I generally don't treat it, but as Tim suggested in his talk, I would follow it up during pregnancy.
Yeah, I totally agree with that. I mean, it is a sensible argument that you hear sometimes to start iodine supplements in women who aren't, for example, on any multivitamins that contain iodine. Although the link between iodine deficiency and hypothyroxanemia is actually not that strong if you dive into the data. But in general, yeah, I agree. There's no real indication to treat it as for now.
There's also someone who asked about why should we have TSH target below 4 before starting treatment and TSH target below 2.5 on treatment.
Yeah, so the difference between the 4 millunits per liter cutoff and the 2.5 treatment target is exactly that. So we used a cutoff of 4 millunits per liter to diagnose any abnormal TSH concentrations. But then when we treat a woman and we actually have full control over what the thyroid function is going to be, we pragmatically recommend to titrate to a TSH less than 2.5. And that is mainly because we know most otherwise healthy pregnant women will be there in that range. And also because it gives us a little bit more wiggling room in case the demand for thyroid hormone increases during pregnancy, so that we are sure that we don't undertreat women who are treated with levothyroxine.
Thank you. Carla, do you have any comments or questions for Tim?
The only question I had is that, Tim, you showed a nice slide when you were talking about discontinuing anti-thyroid drugs early on in pregnancy. But it seemed like on the slide you were suggesting that the risk of the Graves' disease relapse was increasing throughout the course of the pregnancy.
So that is after stopping the anti-thyroid drugs. So as Kristien pointed out, somewhere during the second trimester, there's going to be a shift in autoimmune disease susceptibility in general, but also in the risk of having a Graves' flare or more severe disease. But right between that point and early pregnancy, when you stop the anti-thyroid drugs, that risk is probably going to increase because we stopped the therapy. And there you have the risk that there will be a relapse in some women. That's what I was trying to indicate with that slide. But I think in generally, like you said, it's the other way around, and the risk or really the severity of Graves' disease will decrease during pregnancy.
There's a question about, could you comment on treating ladies with TRHB during pregnancy?
You want me to go first? So I've treated 2 ladies, I think, who have resistance to thyroid hormone with a mutation during pregnancy. And of course, interpretation of thyroid function test is difficult. I mean, generally, what I like to see is sort of similar thyroid function tests during pregnancy compared with outside. Most people with resistance to thyroid hormone actually don't need treatment. Now, pregnant women will get palpitation whether they have a thyroid problem or not. And if that becomes troublesome, then certainly I try to give them a beta blocker. My obstetric colleagues aren't necessarily all that happy with giving beta blockers. I'm usually okay to twist their arm in the first and second trimester. They certainly become more concerned in the third trimester. But I think it's about having significant changes in their thyroid function that would make you worry, and then also based on patient symptoms. Tim?
Yes, that's absolutely right. And I think the main risks are also related to whether or not there is a mismatch in the genes between the fetus and the mother. I'm not sure that is something that we can, already diagnose prenatally, and whether that would actually have any effect of the way that we treat these ladies. I don't think that's very relevant from a clinical point of view. But the studies seem to indicate that, if the fetus doesn't carry the mutation and the mother does, that the effects of the hypothyroidism can be more severe. Not sure if Edward or Carla wants to pitch in here, because it's a nice overlap of the two talks, I guess.
Yeah, I think, well, there might be indeed two possibilities. Either the fetus is wild type or has the mutated TR beta. I think if it's the latter, then usually we assume that also the fetus is compensated. If there's a wild type child, then probably it may suffer from the thyrotoxicosis. I think there's one study showing that in such cases there's a higher chance of miscarriage, and also a lower body weight at birth. But it's really difficult whether you should pursue prenatal testing, because that's not possible early in pregnancy. Well, miscarriage, at least in that study, I think that took place before the 12th week. So we are inclined to have, let's say, a very high threshold for prenatal testing, because it usually do not change your management, and there's also a risk, obviously, associated to prenatal testing. And yeah, so I don't know, Carla, whether you have any other suggestions or comments.
Yeah, no, I do the exact same. I think some others have suggested that prenatal testing should be considered, and if the baby is wild type and the mum is RTH beta positive, that one might consider giving antithyroid drugs in order to lower the T4. But that hasn't been our practice. So yes, we just manage their symptoms, and in the majority of cases that I've looked after, the outcome for the baby has been very good.
I suspect most non-specialists send tests to the lab and assume the answers they get are the answers as they should be. Can you comment on European or other guidelines in terms of what should be happening? In other words, the lab side, they have an abnormal result. To what extent should they have multiple testing variants available in the lab, or refer on to other labs in partnership to make things as good as possible for the clinicians and patients?
If I may kick off, if it comes to testing for thyroid, I think the first test should be just TSH, and that basically rules out nearly 100% of thyroid disease. So I think many occasions when there's interference or something strange with FT4 is actually because someone in some way kind of mistakenly ticked the FT4 box. Well, that was not necessarily needed. On the other hand, it seems to become more and more common practice to request both TSH and FT4 already in the first place. Yeah, I think it would be good if there would be some way of engagement between the doctor who sent off the bloods to the lab, and the lab to comment. So we have something here in place in our hospital, but I think ideally it would be nice to have it in different places, but it might be, for example, in GP practice, it might be difficult to organize something like that. Yeah, I don't know what the others feel from an organizational point of view as well.
Right, so maybe I could cover. So our NICE guidelines, which are excellent, of course, state that, you know, the way you should do thyroid function testing is measure TSH, and if that is abnormal, then you measure free T4 and or free T2, depending on whether it's up or down. I think most hospitals and testing laboratories, if you have a funny thyroid function test result, that will send a message automated to the GP saying, this is not right, please consider referral to an endocrinologist. And, you know, I think unlike you, Edward, where you say, you know, most of the patients you get, they've already been worked up with alpha subunit SHBG, you know, those would then be the tests that come to us. When we had the Roche assay, where, you know, notoriously that reads a very high free T4, and we had a lot of patients with funny thyroid function tests. So the GPs would automatically get notified. They would come to us, and in most patients, all I had to do was measure it on a different assay, the one we use in the women's hospital. That would be normal, and then we say this is Roche hyperthyroidism, essentially.
There was a recent article, I think it's Thyroid, which stated that FT4 was the primary test to do, not TSH. Although I was always educated with the TSH as the first line test. Could you comment on that?
I think I know about that article, and the main suggestion that was made in that article was based on the fact that if you look at clinical outcomes, then free T4 seems to be a much stronger marker for the risk of those outcomes rather than TSH. So this is true in pregnancy when we look at IQ of the child and preterm birth. It's also true outside of pregnancy when you look at atrial fibrillation, sudden cardiac death, and depression, for example. I think, you know, the way that I typically approach these issues is the other way around. So, you know, I have a patient sitting in front of me, and then I'm going to think, what am I going to do, and how is the bloods going to help me, and which bloods do I really need? So, for example, if I'm not going to treat hypothyroxanemia in pregnancy, then there's really no need to check the free T4 concentration if you want to check someone's thyroid function during pregnancy. And I think from that perspective, you know, you really need to think, am I going to treat somebody who has an abnormal free T4 and a normal TSH in any sense, before you do a test as a GP or, you know, as a second line general medicine physician, for example.
Well, on that point, I'd like to thank all our panel for a tremendous session today. Just to let you know, there will be a recording of this available free on the FPM website from early next week. We'd also be very keen on feedback from our audience in terms of the session, anything you might have wanted to hear more about, or any questions you may have unanswered during this session. But again, thank you very much indeed. We will let you know about future webinars. These are monthly updates. And just to finish, to let you know, the FPM is hoping to be back in real world times before too long for real conferences, but we are planning in current COVID times to have 2 virtual conferences this year, one as Advances in Medicine, which follows it in our series of annual conferences at the Royal College of Physicians in London. And these will be opportunities for people to submit abstracts to show their work, as well as to have invited panels on the lines of today's session. We're also celebrating the 10th anniversary of our health policy journal, and we're again planning a virtual conference series over the summer, about which we'll let you know more later on. But on that note, thank you all again very much indeed. Could I just ask